TopMedTalk.
Well, hello and welcome to TopMedTalk. We are at Euroanesthesia 2022 in beautiful Milano, Italy, coming to you live from this very busy trade exhibition. I'm Desiree Chappell, and I'm joined by Monty, Mythen, my co-host. Hello, Monty.
Good morning, Desiree.
Well, let's get right into it. We wanted to introduce our first guest, Dr. Dan Sessler from the Cleveland Clinic. Hello, Dan. How are you?
Good morning. It's a pleasure.
Thank you so much for being here. Dan, for everyone listening, tell us a little bit more about yourself.
Well, I chair the Department of Outcomes Research at the Cleveland Clinic. I also direct the Outcomes Research Consortium. The Consortium is the oldest and largest clinical anesthesia research group. We're quite productive. We publish a full paper every 2.5 days.
Oh, I was going to say, I thought there was a lot coming out of that. I didn't realize that's how busy you are.
Yeah, well, the Consortium has published more than 1,600 full papers.
Wow, that's impressive.
To put that in perspective, that's equivalent to every paper in every issue of a journal like Anesthesiology for 12 years running.
Oh my gosh. Well, congratulations to you guys and the team there. That's very impressive, actually.
I'm going to move us on to POISE-3, the third in the POISE series. And this was a large trial, multi-center international trial, Factorial Design. And the first paper, I think, is already published in the New England Journal of Medicine, Dan?
Correct.
Can you tell us about the Factorial Design? There's a lot to squeeze in. Because then we'll talk about the first result, the tranexamic acid. Then we'll talk about blood pressure.
Okay. Factorial designs are one of the trial innovations that's being increasingly used, and for good reason. Because with a factorial design, you can answer 2 or more questions simultaneously. So that's obviously very efficient, but it's actually even better than it sounds. Because if you do 2 independent trials, you can't tell what happens if you combine an intervention. With a factorial design, you can look at the interaction time term and tell whether these interventions interact additively, whether they antagonize each other, or whether they might be synergistic. So factorial designs are really powerful. POISE-3 had 2 factors. One was tranexamic acid, and the second was blood pressure control. So patients were randomized to tranexamic acid or placebo and to hypotension prevention or hypertension prevention.
Now, I'll bring you back to that in a second. We're going to concentrate on the rest of the podcast about blood pressure. But the takeaway from the tranexamic acid trial results. So big trial, about 9,500 patients,
correct.
100 plus countries, 20 plus countries, is it?
It's 120 centers in about 20 countries, so 9,500 patients enrolled.
So a huge effort. Well, what's the takeaway from the tranexamic acid trial?
Tranexamic acid works. And that's not super surprising because many previous small trials have shown this. But this is by far the largest, by an order of magnitude or something like that. It shows clearly that tranexamic acid reduces bleeding, it reduces transfusion requirements, and importantly, it shows that it does not increase cardiovascular events, because the cardiovascular events after surgery are type 2 infarctions. They're supply-demand mismatch, and coronary thrombus is probably one of the factors. So it is quite possible that tranexamic acid, while reducing transfusion requirements, would promote cardiovascular events. And it turns out that's not true. With a fair degree of confidence, we can say that doesn't happen.
Now, some people might walk away and say, well, it made some difference to bleeding, but it didn't make an obvious difference to what we refer to as outcomes, very meaningful long-term outcomes. But the thing that was brought up in the presentation is there's a blood shortage. So the amount of blood that could be saved that didn't need to be transfused makes a huge difference.
Well, there's not enough blood in the world. So people who need transfusions don't always get them. That's not so true in Western countries, but in many countries, people simply don't get the blood they need. Tranexamic acid is generic. It's been around forever. It's dirt cheap. It appears to be incredibly safe. There's no reason not to use it. Another thing that came out of this is that it wasn't just big operations at high risk for bleeding. it helped across the entire spectrum of operations. So even though surgeons say, oh, I'm not going to have bleeding in this operation, which they say for every operation, okay, you still should give them tranexamic acid because some of them will actually have major bleeding. And if you have the tranexamic acid on board, it prevents a catastrophe. So it wasn't just transfusions. It also reduced major life-threatening bleeding-related events.
Brilliant. So that's out there. People can read it in the New England Journal of Medicine. Now, the second component of it, which is what we're going to talk about for the rest of this podcast, is the blood pressure story. And this was a more complicated thing to try and assimilate in a short presentation.
It is. Yes.
Can you give it your best shot, elevator pitch?
Okay. So this was a partial factorial randomized trial. So not everybody who qualified for the tranexamic acid part qualified for the blood pressure part of the study. To be in the blood pressure part of the study, patients had to be taking antihypertensive medications. So the result was that we had only, as it were, 7,500 patients. Now, 7,500 patients, of course, is still a huge trial, and the results are highly clear. Patients were randomized to hypotension prevention, which meant keeping intraoperative mean arterial pressure above 80 millimeters of mercury and delaying the restart of their chronic antihypertensive medications for 3 days. Patients randomized to hypertension prevention were allowed to become hypotensive to as low as 65 millimeters of mercury during surgery, but some got lower than that. And their antihypertensive medications were restarted immediately after surgery. So intraoperative blood pressures ended up differing. There was about a 30-minute difference in the amount of hypotension between 60 and 69 millimeters of mercury. An unfortunate limitation of the trial is that we don't know what happened within that range. So it's possible that most of that hypotension was well above 65, and not that many patients were down around 60. Starting or restarting antihypertensive medications seems to have almost no effect on postoperative blood pressure. And that's important because myocardial injury after non-cardiac surgery, as far as we can tell, does not occur intraoperatively. It occurs postoperatively. 94% of these events would occur within 2 days after surgery, but probably not actually during surgery.
So that's where I want to take us for the last section of this, and we'll introduce another guest in a second. Are we calling all these trials negative, if you see what I mean? Is it just that we might just be looking in the wrong place? We're looking under we're looking under the lamp. We're not looking where we drop the keys.
Right. Okay, so I need to give you the results. The results were that it didn't make any difference.
Okay.
Whether you were randomized to hypertension avoidance or hypertension
I was taking that as a given
avoidance.
at this stage.
Okay. No, it did not make any difference. That doesn't, of course, mean that blood pressure doesn't matter. Because there was almost no hypotension below 60 millimeters of mercury. Without question, hypotension at some level injures organs. We just don't know what the threshold is. And a limitation of POISE-3 is that it doesn't really tell us where the threshold is. It's somewhere between 60 and 69, perhaps, might be a little bit lower than 60, but personally, I would not leave a patient sitting at 60 millimeters of mercury for the whole case. The bulk of available evidence, granted lots of it's observational, is that that's probably harmful. So POISE-3 helps, but it doesn't tell us exactly what the threshold is. There is another trial called Guardian that's already started that will randomize 6,250 patients. These will be higher risk patients. All the patients will require an arterial catheter. The blood pressure control will be a lot tighter, and we will have near continuous blood pressures in these patients. So we'll be able to identify a threshold.
And when you aim for that, because the higher threshold group, the one that we thought was going to try and achieve an 80, for example, did not look as though many patients got to the 80. Will that be more so in the Guardian trial?
In Guardian, the higher threshold will be 85 millimeters of mercury. And in the lower group, based on the POISE-3 results, we're actually hoping that we have blood pressures in the 60 to 65 range, because I suspect that the threshold is in that range.
TopMedTalk.
Desiree Chappell with TopMedTalk. It has been an exciting year, and there is so much more to come. Now I'm joined here with Monty Mythen. Monty, what is coming up?
Well, next TopMedTalk are going to be coming to you live from the European Society of Anesthesiology from Milan in Italy. You'll find us on the GE booth in the trade exhibition. We'll be there intermittently, and we'll probably pop up in a few other places. So I'm there with Desiree, and Sol Aronson's coming in, and Henry Howe. And after that, Desiree, where do we go?
It is time for the 25th anniversary World Congress of Perioperative Medicine in London, right? Live.
From the UCL campus to celebrate our 25th anniversary. So that's really exciting. And then I think we've got the next one in August with your organization in America.
It is. It's in Chicago. It's the American Association of Nurse Anesthetists. Monty and I are going to pop up there, have some great conversations, and then it's on to
Dingle. So that takes us into the autumn and winter season. More about that to follow.
And then, of course, we're going to be rounding out the year with the American Society of Anesthesiologists in New Orleans for their annual Congress. So super excited about all the events for the year. Don't miss us. Be sure to check us out on TopMedTalk.com and on your favorite podcatcher. We are there with late-breaking anesthesia and perioperative news. Right, Monty?
Absolutely. See you soon.
Cheers.